Okay, hi everyone. Welcome back from lunch. My name is Trisha Tan. I'm going to chair the session this afternoon. I'm going to first introduce you to our first speaker, Dr. Sophie Dream, who's an associate professor in the Division of Breast and Endocrine Surgery. She's also the first author of the American Association of Endocrine Surgeon Guidelines on the definitive surgical management of secondary and tertiary renal hyperparathyroidism.
Thank you. Thank you so much for having me. Hopefully we can maybe catch up on time. I talk a little fast, so yeah. I'll be fine. This will be great. So I'm going to talk a little bit about pathogenesis of kidney-related parathyroid disease, which I think is important to understanding parathyroid disease in general. Describe how we diagnose it, benefits of parathyroidectomy, kind of focusing on skeletal benefits, and then indications and how we do the operation. So kidney-related parathyroid disease. Hyperparathyroidism happens in the setting of kidney disease because of alterations and adaptations to calcium, vitamin D, and fibroblast growth factor 23 levels. It's almost a universal phenomenon in patients with kidney disease, where 40% of patients with CKD grade 3, 82% of CKD grade 4, and every patient with grade 5 or patients on dialysis will have hyperparathyroidism. Parathyroid hormone, I'm sure everyone in this room knows what it does, but just a reminder, increases maintains calcium homeostasis through increasing bone mineral dissolution, so releasing calcium and phosphorus from the bones, increasing kidney reabsorption and filtration of calcium and excretion of phosphorus, increasing the activity of the kidney to convert vitamin D into its active form, and then enhancing GI absorption of calcium and phosphorus through its effects on activated vitamin D. In chronic kidney disease, the kidney loses the capacity to maintain calcium and phosphorus homeostasis. So you get a decrease in the production of calcitriol and an increase in FGF23. And those then cause retention of phosphate, decrease in calcium, and an increase in parathyroid hormone. With the increase in parathyroid hormone, you then start to see hypercellularity of the parathyroid glands, and the glands enlarge over time. So you'll see in patients that have secondary hyperparathyroidism glands that are as big as 500 to 1,000 milligrams in size, which we usually want to see them to be about 20 milligrams to be normal in size. And over time, that process then becomes nodular, and then the parathyroid glands become a little bit resistant to vitamin D and calcium. When you start to have adenomatous changes, those vitamin D and calcium sensing receptors are non-responsive to parathyroid glands, so you start to get autonomous function. All of this is to say that the calcium, the bones, and the parathyroid glands interact quite readily, and especially when one of these things is not working the way it's supposed to, the other things will see effects, and you will see bone disease from this. So parathyroid disease is in kidney disease is an adaptive process. So we know that the skeletal effects of uremia make the bones a little bit resistant to parathyroid hormone. And so these studies from the 1970s, the first study looking at uremic dogs and the role of vitamin D in the skeletal architecture, show that with lower vitamin D rates, the bones are a little bit resistant to parathyroid hormone and maintaining bone health. And then that study was then followed up in human subjects that show that both vitamin D and PTH levels, the effect of it is blunted in patients who have uremia, and that effect can be overcome with higher levels of vitamin D and parathyroid hormone levels. So with that, we know that patients are subject to adynamic bone disease. So with kidney disease, these patients will have low bone turnover and normal mineralization if they have normal parathyroid hormone levels. The other thing that's a caveat to adynamic bone disease, the way to diagnosis is through bone biopsy. So you have a reduced number of osteoblasts and osteoclasts, and those cells that are there are not quite active enough because they don't have enough PTH to make them active the way they're supposed to be. And this can come from either renal hyperparathyroidism or oversuppression of PTH, which we see with really high doses of vitamin D and calcium mimetics, which I'll talk about a little bit later, is how we treat CKD parathyroid disease. This also increases the risk of fracture. But you don't necessarily see it on DEXA scan because the bones have normal mineralization. So they will look pretty normal on imaging, which is why you have to diagnose it with bone biopsy. So risk factors for adynamic bone disease, again, high dose vitamin D, phosphate binders, calcium mimetics, anti-absorptive agents, aging, diabetes, hypogonadism, and the peritoneal dialysis. So we do know that low PTH and PTH suppression is a risk factor for bone disease and parathyroid hyperparathyroidism. The other thing that we know is with PTH being too much, it's also detrimental. So you start to see renal osteodystrophy and osteoporosis, where you have really high rates of bone turnover and abnormal bone mineralization. So those bones are pretty weak and have low density. That also will cause vascular calcification in the medial layers of the vessel because you have increased calcium and phosphorus levels from all of that bone mineral dissolution. And so this DOPS trial was done in 2020, and they looked at balancing what the PTH level should be to maximize cardiovascular morbidity and mortality. And when they corrected for all of the things that you would correct for in a patient with dialysis, which is a lot, you find that the cardiovascular morbidity and mortality is best suited to keep a PTH less than 600. So anything above 600 is not so great for your heart. So then I don't want to go through this there's a lot of data on what the PTH level should be to optimize your kidney, your bone function, and renal hyperpara. This was actually done before the DOPS trial. So if you're looking at balancing what the PTH should be, the low end and then the high end to balance adynamic bone disease from renal osteodystrophy, you need to be above about 150 and below about 300, 350. When we wrote the guidelines, we put in 150 to 600 because 600 is that upper limit for cardiovascular morbidity and mortality. To ask everyone to get patients into a spot that's like 150 to 200 is really tough in the OR. If you've ever done parathyroid surgery, you're kind of guessing where they're going to land. So we left this broad range because it's very acceptable. Initial management, though, calcitriol to maximize PTH suppression and minimize calcium and phosphorus absorption in the gut. And then calcium mimetics are used to decrease PTH and calcium levels. And the EVOLVE trial showed that when you're comparing it to a placebo, calcium mimetics are really equivalent. They're non-inferior. So on that note, after the EVOLVE trial and all the DOPS trials, sometimes you ask the Cochrane database if they have the same question as you, and sometimes they've done this, they've done the review. So there's this really nice Cochrane review that looked at patients on calcium mimetic for secondary hyperparathyroidism and reviewed whether or not it's beneficial. It's 18 studies, over 7,000 patients, comparing patients on cinacalcet and standard therapy versus patient on a placebo or no cinacalcet and standard therapy in patients on dialysis. This study, overarching, says you do reduce PTH, calcium, phosphorus, and reduce biomarkers of bone turnover. When you look at cardiovascular morbidity and all-cause morbidity, it's about the same, placebo versus being on a calcium mimetic. I don't really like this outcome, but it prevented parathyroidectomy. I don't think that a really good definitive treatment is something we should be preventing, but you can prevent it with the calcium mimetic. And then hypercalcemia, we do know that you're suppressing the calcium release in the bone. So it's obvious that would be prevented. And then you increase hypocalcemia, nausea, and vomiting in these patients. So they do have negative side effects from being on calcium mimetics. The one caveat to using calcium mimetics is the data is not sufficient to assess bone disease. So most of these studies will look at biomarkers of bone turnover, which is great for assessing renal osteodystrophy, but it does not assess for adynamic bone disease because you won't have those biomarkers being elevated because you don't have that really high, you do have normal bone mineralization. So sometimes those markers will be normal. This data, although, does not show like bone biopsy because nobody's really doing that, even though that's gold standard. So we don't know that these patients don't have risk for bone disease or adynamic bone disease. So there's still a lot to be done on whether or not calcium mimetics are helpful. Parathyroidectomy does also reduce PTH, calcium, and phosphorus. There's also lots of things that parathyroidectomy does that helps really reduce the deleterious effects of parathyroid hormone toxicity and renal hyperparathyroidism, including cardiovascular morbidity, mortality, renal osteodystrophy, like health-related quality of life, cognition, and then cardiovascular artery, coronary artery calcification. So it can be very beneficial in the right patients. So This is from the American Association of Endocrine Surgeons guidelines for renal hyperparathyroidism. The recommendation that is made in that document is actually quite conservative. We were trying to make a recommendation to reduce cardiovascular and all-cause mortality. So we say parathyroidectomy is really for refractory medical management, which means a PTH exceeding 9 times the upper limit of normal and having one of these other comorbidities associated with renal hyperparathyroidism, which we do know that there's probably looser indications. This was just the first iteration of these guidelines, so I think we were rather conservative when we put this together. Okay, so kidney-related hyperparathyroidism exists on a spectrum. So there's secondary disease, but then we know that these parathyroid glands go on to be autonomously functional. So that's usually when you become in the setting of tertiary hyperparathyroidism. You can see it in the pre-transplant setting. I know historically we talk about tertiary hyperparathyroidism as parathyroid disease that persists after the underlying cause being corrected. But in patients with kidney disease that are on long-standing dialysis, oftentimes we'll see the patients have elevated serum calcium, and that's just telling us that those glands are no longer listening to the signals they're getting and that they're probably autonomously functioning. So those patients would benefit from parathyroid surgery in the pre-transplant setting. Tertiary hyperparathyroidism happens in about 20 to 80% of patients in the post-transplant setting. The biochemical changes can persist for 9 to 12 months afterwards. So you can have normalized PTH in about a year after transplant surgery. And then the benefits are to normalize hypercalcemia, hypophosphatemia, to help with bone mineralization, and then to preserve renal allograft function, which we know at this point, delaying parathyroidectomy over a year after renal allograft kidney transplant is really bad for the kidney. So we usually try and get these patients in pretty early. The other thing I think that sometimes goes unrecognized is post-transplant bone disease. So these patients have a higher risk of fracture. It's 3.6 to 3.8 times a patient population that's normal healthy controls. And then patients who have had kidney disease are 30% higher to have a fracture in that first 3 years after transplant when compared to patients on dialysis. I think this is somewhat related to the fact that these patients have been exposed to renal bone disease for quite a long time. But then these patients are on immunosuppressive agents that also affect bone formation, bone reabsorption, and bone necrosis. So they have this double hit that makes them a little bit higher risk for fracture. So it's really important to consider this. Even though the patient might not have really high calcium, they're still at risk for bone problems. So you just want to remove anything that's going to make it worse. Okay, so in the guidelines, we had recommended that patients be referred for surgery within that first 12 months. Even though the PTH can normalize, we want to make sure that they're coming in and seeing us. These patients have a lot of other comorbidities, so we want to make sure that they're optimized for the operating room as soon as possible if they're going to need to go. So oftentimes we'll see them that first 6 months. And that the parathyroidectomy is really the treatment of choice for hypercalcemic hyperparathyroidism in the kidney patient. So we talk a little about surgery and how we do this operation. The goals of surgery is to decrease the source of PTH excess. And then we also are balancing the risk of permanent hypoparathyroidism and recurrent or persistent hyperparathyroidism. In the transplant setting, we always consider whether or not the patient is going to get a kidney transplant and whether or not they're on dialysis. Some of this is for postoperative management. So patients that are going to be on dialysis are a little bit easier to replete their calcium. And when we're thinking about how big of a remnant to make, sometimes if they're in the pre-dialysis, pre-transplant setting, it might leave them with a little bit more parathyroid tissue because I might want their PTH to be a little bit higher to help them manage their calcium. In the post-kidney transplant patient, we usually want to make sure that that patient's cured because they don't need that PTH to be high. We always look at all 4 glands. We want to make sure that we're identifying them before resecting anything. The parathyroid glands want to make sure that they're handling them carefully to avoid capsular disruption. Number 1, to maintain the blood supply, but also want to make sure that they're not getting parathyroidmatosis. And then usually prefer doing a subtotal parathyroidectomy, leaving behind a well-vascularized remnant. That's the best way to maintain, to prevent post-parathyroidectomy hypoparathyroidism. And usually choosing the most normal looking gland to leave that remnant because that's going to help with recurrence. So subtotal parathyroidectomy, again, is preferred for secondary, tertiary once you find all the glands. We're weighing the risk of permanent postoperative hypocalcemia and persistence. Sometimes a limited resection of just one gland is appropriate, not necessarily to do like a minimally invasive parathyroidectomy doing dual imaging, but if we go in there and we see all 4 glands are normal and there's just one big parathyroid adenoma, then we leave it to that surgeon to say, yes, this is the rare patient that had primary hyperparathyroidism in the setting of kidney disease, and they will be cured with just one gland coming out. So, but we would say that you do that once you've identified all glands and make sure that the rest of them look normal. The last thing I was kind of going to talk about is this, the concept of total parathyroidectomy without autotransplant. This is pretty uncommonly performed. It's really to decrease the source of parathyroid excess and to eliminate the risk of persistent or recurrent disease. In these cases, the patients are really relying on parathyroid rests or supernumerary glands. So if we're taking out all 4, we're assuming that there's something in the thymus that's embryologically sitting there that's clinically going to be functional. We don't recommend doing total parathyroidectomy without autotransplant in patients that are going to get a transplant or in patients that have tertiary hyperparathyroidism, because they really do need parathyroid function to have a normal lifespan. So it's really just in those cases where we know that patient's not going to get a transplant, and there's really cardiovascular long-term health related quality of life benefits to doing parathyroidectomy and reducing that parathyroid burden. The one other thing I think that always comes up is whether or not we use intraoperative PTH monitoring. In this case, it's really tough. So patients that have kidney disease, their PTH kinetics are very different because they have renal disease and they have sometimes some underlying liver metabolism that's not so different to a normal baseline. So the decrease in PTH is not what we would expect for someone who has a normal kidney. And so that half-life is longer than 5 to 10 minutes. So in these cases, there's not really a standard for what that should look like. What should the PTH drop should look like? So in the guidelines, we had recommended that the surgeon can make the decision to use it or not, but they should really understand the data. And so this was a review of all of the papers that were out there. And it's in the guidelines if you want this table. But the way I have started to practice after looking at all of this stuff and putting the guidelines together is I will do a 25-minute PTH. And if it's dropped by 50 and it's trending to kind of leveling off, I usually feel pretty good about that by 50%. I don't use, some of these studies will use a threshold of like less than 200. I get nervous because those patients sometimes nadir out overnight and their PTH will be like 2 the next morning. And I get really nervous because I want them to land at 200 a week later for their bone health. So I'm a little bit cautious about being really aggressive with intraoperative PTH monitoring these patients. That is it. Happy to take questions.
Hey, any questions from the audience?
Thank you, Sophia. Really nice presentation. And it's the disease that's really changed in my professional lifetime because the availability of donors has gone up. So when I started, the chances of our patients ever getting a transplant was so low. And so we follow you're recommending, and we leave tissue behind now. I just wanted to ask what the attitude in Alabama is to the thymus, because for a long time it was a matter of considerable debate here, but I think now we've come to a conclusion. I just wondered what your thoughts are.
Yeah. So I don't routinely perform thymectomy in these patients because I know sometimes these patients, especially if they're not gotten a transplant yet, they might end up coming down the line needing a second parathyroid surgery because I get them to a place where they look good. And if that patient doesn't get a transplant in that next year or so, their PTH will creep back up and I'm looking at trimming that thing back down again. I've had cases where patients have had parathyroidectomy and then like repeat operations, we talked about taking the thymus out to kind of reduce the risk of recurrence again. Unless there's really like I'm in the OR, I've taken out the glands that I think are normal and I've created my remnant and it's not dropping by that 50%, that's when I would do a thymectomy. I know there's a study out there that looks at just doing SPECT CT on everyone. And if you see a gland in the thymus, sometimes people will say like you either take it out or you do imaging. I think we can be a little bit more pragmatic than that and not just make a blanket statement about doing one thing or the other every single time. Yeah.
May I ask a question?
Yeah.
The use of intraoperative PTH is controversial.
Yeah.
And of course, these patients with secondary hyperparathyroidism in particular are not necessarily hypercalcemic.
No.
So the whole principle of intraoperative PTH is that the high calcium suppresses the PTH once you've removed the abnormal parathyroid glands. But when you're doing a 4-gland exploration, by definition, you're finding 4 glands. So if your PTH doesn't fall and you've seen 4 parathyroid glands, where do you go?
Yeah, that's when I would take out the thymus. I usually go into the OR for these patients in my mind, knowing like how big, how chunky of a remnant I'm imagining leaving behind, and whether or not that in that patient's a whole gland or like a quarter of a gland just depends on what the glands look like when I'm in there. I think the hormone level I use to help me be reassured that I've not left an ectopic gland somewhere. And so if it's not where I expect it, the most likely place is going to be in the thymus, because any parathyroid rest cells in this disease process is going to become clinically relevant, because those cells have seen pathophysiology that would not have suppressed the cells from, you know what I mean? So I think, and the most likely place you're going to see that is in the thymus. So I usually would pull the thymus up and then check a PTH like 25 minutes later, but.
Okay, can I ask a question?
Yeah.
That's very loud.
Yeah.
When and how do you decide on the timing of surgery in these patients? I know you mentioned about post-transplant.
Yeah.
But how about the ones on dialysis and pre-transplant?
Yeah. I honestly think at this patient, once the patient has been referred to us as a surgeon, that's usually when they need it. They're usually coming to us a little bit later than they should be coming to us. I think almost if the PTH is 600 or higher, they should really be seeing us. Yeah.
Trisha, I would answer what happens here.
Yeah.
So we broadly adopt the KDIGO guidelines. So, which means any patient that's hypercalcemic, that's a given. Calcium phosphate product of greater than 4.1 is a trigger. PTH of greater than 90 picomoles per liter. It's actually slightly less than that because it's converted from American. So we broadly use that as a guide, because the rationale for that in a pre-transplant patient is that statistically, if your PTH has hit 90, whether it's a 90.
Yeah. Okay. Yeah. That's fair. Yeah. 90. It's like
statistically, the chance of reversal after a transplant is pretty low. Much lower.
Yeah. The other thing we know, there's a very large growing body of research that shows if that PTH is at about 900, it's actually pretty bad for the kidney itself. So that patient getting a transplant, you want to preserve the kidney. So yeah, 900 is a good threshold, but you probably could go lower, to be honest. Yeah.
I'm more familiar with the data and the graphs on what happened to referrals for parathyroidectomy in renal patients with the introduction of cinacalcet, and a big drop off in the number of parathyroidectomies done for a period of time until most of those patients rebounded. So I wondered what you are seeing, or whether you are seeing the introduction and use of etacalcetide as a better tolerated intravenous agent given at the time of hemodialysis, and whether that's having an impact on your practice in the state.
I think it has reassured the nephrologist, because they see the numbers and they say that the numbers are fine, so we're probably okay. But again, nobody's doing these bone biopsies, and so I don't think we actually know what we're doing. But then these patients, I think, feel actually pretty miserable. The one thing I have seen with calcitide is the patients don't know they're on it. We don't have access to the dialysis records, so they get referred to us, and I'll ask them if they're on a calcimimetic, and they don't know. And then if we call the dialysis center, somehow get a hold of someone, they are, for the most part, on it. So I actually think it's become this thing where it makes the numbers look great, and it's really hard to discern if a patient's taking it or not. And so I just get worried that we're not. Oh, and a lot of the studies are actually sponsored by these drug companies too. So I get a little bit testy about it. I don't know. Yeah.
Hi, for a non-surgeon, how do you decide which is the best looking parathyroid? Is it just visual inspection? Is there any other means by which you decide this is the best one to auto-transplant?
Yeah. Luckily, I trained at a place where we looked at a lot of normal hormonal, normal calcemic No, I'm just joking. No, we do a lot of foregland exploration in our practice, and I trained with Dr. Chen. So I've seen a lot of normal parathyroid glands. So I feel very confident that I know what a normal gland looks like, and I know what looks abnormal. Oftentimes in renal hyperparathyroidism, we will see these glands do have like atypical changes, and they'll have calcification, and they'll be really big and nodular. And so if you run across a very normal gland, it stands out pretty easily, especially in that operation. So it's pretty easy to decide which one is the most normal looking. But I do think that doing a lot of foregland exploration really helps you discern normal from abnormal. The other thing is the group here at Hampstead is working on some stuff to help you to identify normal without experience. So I think, or Hammersmith, yeah. So I think we're kind of getting there.
We have a lot of patients referred now who are on renal dialysis, and someone does a DEXA scan, shows they've got low bone mineral density. And my heart sinks because they come to our clinic, and I can try and find out which type of bone disease by looking at bone markers. But shouldn't we be, but there's no treatment of ours which is really in any way able to be used, or doesn't have extraordinarily bad side effects like hypocalcemia. So do you think we should have a different PTH cutoff if they've got demonstrated low bone density or are fracturing?
Yeah, I think the cutoffs are rather conservative. I do think I think part of the reason the KDIGO guidelines and then our guidelines we wrote our guidelines with a lot of leaders in nephrology in the US. So I think our guidelines are also mirror some of those, the KDIGO guidelines. I think a lot of those are like the threshold is based on the nephrologists, I think, have had historically surgeons who had gone in, done parathyroidectomy and left the patients with a PTH level that's too low. And then they're struggling to maintain the calcium level being normal. And then they're also you're not really doing anybody a favor in this disease process by making the PTH too low as well. So I think people are used to primary hyperparathyroidism. They want to see the numbers normal, and that's not really what we should be doing in this case. And so I think everyone was very trigger shy to send the patients. I think the more surgeons understand this disease process and are a little bit more cautious in what we're doing, the more likely we're going to be seeing more of these patients, because I do think they would benefit from parathyroid surgery earlier. It's just like us as a group getting on board with our
delighted if you write us some guidelines for earlier. So that would be wonderful. But we find this very difficult.
Yeah.
Any other questions? Okay, well, thank you very much, Dr. Drew. Okay, so I'd like to welcome our next speaker, Dr. Lindemann, also an Associate Professor of Surgery and Medical Education at UAB. She's also published extensively with a focus on adrenal incidentalomas. So we're looking forward to this talk.
Well, good afternoon. Oh, that would be lovely. Thank you. Excellent. Let's see if I can figure this microphone technology out. Can you all hear me all right? Perfect. Okay. I just, again, want to reiterate what my colleagues have said. It is a true honor and privilege to be here with you all. We certainly have enjoyed our visit. I'll put up my disclosure slide. I don't have any financial conflicts of interest. This is my first time in the UK, and it has been such a tremendously warm welcome, and I'm very appreciative. I also felt the need to give a small plug for the Association for Academic Surgery. If there are any surgeons in the audience, particularly those at the early stages of their career, that's our focus as an organization. We have lots of international members. We would love to include you. It's a great way to kickstart your academic career. I also wanted to give a little bit of context because I'm asked to give, with apologies, context with apologies. I was asked to give an American perspective about adrenal incidentaloma, and I thought that this photo particularly emphasized how large our country is and how regional it can vary. We are located south in Alabama. You've seen that. But, they're coastal cities, many different trends. The other thing I wanted to highlight that's important when talking about adrenal disease is I'm not sure exactly when these data are from in the UK, but an obesity rate of 27% compared to ours in 2021 of 40%. You'll note that Alabama is has one of the highest rates of obesity in the US. So these are what our patients commonly look like. And I think that also influences some of the things that I'm going to be discussing with you today. And lastly, as someone who has not been in the UK before, and Americans, we get lots of our views from television, so I may have been informed by some of the things from this lovely program, and you have my advance apologies about that as well. Okay, I'll tell you some things that you know as background. Adrenal nodules are not really common. They're found in axial images performed for other indications between 1 to 5% of the time. And if you look in autopsy studies of people that have hypertension, diabetes, or obesity, we see more of them. And we know that those are related to the hormone products that the adrenal gland makes, or at least we highly suspect. But the question we're always asked is, okay, we've figured out there's an adrenal nodule in this person. What do we do about it, if anything? So I had a professor in medical school who's the chief of emergency medicine, and he said that everything can be boiled down to 3 causes, 3 questions, 3 treatments. It all was about 3s. So I will tell you, I'm sorry, I'm getting ahead of myself. So we want to use our guidelines. We have 2 sets of guidelines. I'm going to talk to you primarily about the American guidelines, our American Association of Endocrine Surgeons. But also we'll borrow heavily from the European Society of Endocrinology, and we'll attempt to compare the 2. All right, so back to my professor. 3 causes, 3 questions, 3 treatments for everything in medicine. So I think that also comes into play for adrenal incidentalomas. So we want to answer 3 questions every time we see a patient. 1, is it functional? 2, is it malignant? 3, because I have to extend somehow and make this a 3rd question. Right? I know in the European guidelines, there's only 2 questions, but we have to have a 3rd. And so we're going to call out metastatic. Right? And I'll touch on each of those. I also recognize this is after lunch. People have a postprandial tide. And so we're going to make it a little bit more interesting and pull in some comparisons of adrenal hormones to the emotions from inside out. You can tell me later whether you disagree with me. But here's the adrenal cortex. We'll focus a little bit on our sadness with aldosterone, cortisol embarrassment. You have to agree that epinephrine is anxiety, and that adrenal cortical cancer is fear. So we're going to start there, right? I think most of us have a healthy fear of adrenal cortical cancer, at least endocrine surgeons do. And so I'll present a little bit of relatively new data that have gone to inform the guidelines that were written in the US, published in 2022. This study's from the Cleveland Clinic group, and they tried to figure out, are our imaging criteria helpful in figuring out if this is an adrenal malignancy, specifically adrenal cortical carcinoma? And as we would all suspect, it relates back to size and density as measured by Hounsfield units. They found a lower percentage of malignancy in lesions 4 to 6 centimeters in size than many of us quote at 3.5%, and that Hounsfield units greater than 20 were the most concerning. So they sort of had this algorithm that they proposed, and it has fed forward to the AAES guidelines, which recommend washout characteristics of an adrenal protocol CT should be used to assess the risk of malignancy, and that if the Hounsfield units, if the Hounsfield units are more than 10, we should get an adrenal protocol CT. The European Society guidelines recommend a non-enhanced CT as the first imaging modality. So there's a little bit of a discrepancy here, but I suspect we are going to swing more toward you, and I'll show you some very new data that may support that. But both societies agree that if we have a non-enhanced CT, the mass is homogeneous, the Hounsfield units are low, you don't need to do anything else, no other imaging studies. But if any of those characteristics are not favorable, the Hounsfield units are more than 10, the mass in the European guidelines, the Americans are kind of silent about this, but in the European guidelines, if it's heterogeneous instead of homogeneous, or you have indeterminate Hounsfield units, anything above 10, then you should do at least one follow-up imaging study. we've shown this lovely surgeon's photo a lot today. Dr. Chen had her photo in several slides in his talk. Dr. Romanel, one of our former fellows, she was the senior author now at the University of Pittsburgh on this study. And they looked back at their series over almost a decade. They had 250 patients that had an adrenalectomy. In that series, 21% were malignant. Though I will point out that 30 of those malignancies were something other than adrenocortical carcinoma. So most of those were small. Only 57% were more than 4 centimeters in size. And when they used a cutoff of 20 on their Hounsfield units, then they never found malignancy in a patient with a Hounsfield unit less than 20. So I won't force you to walk through all of this table. I'll point out just a few things. So one was that if we use a cutoff of a Hounsfield unit of 10 or less, then our specificity stays at 100%, but the accuracy is pretty low. And so in their series, their accuracy was improved from 47 to 65% when you used a cutoff of a Hounsfield of 20. And I think the most important piece of their findings was that when you use an adrenal protocol CT with using either the absolute or the relative washout, then you miss. There are 2 patients with other malignant lesions that would maybe not have been worked up further or certainly would not have been taken to surgery. They captured everyone with an ACC, but there were patients with other malignancies that may have benefited from adrenalectomy that were potentially missed. And the other thing I think is important is that in their series, chemical shift MRI had the same accuracy as a non-enhanced CT. And I don't know how it is in the UK, but in the US, an MRI is substantially more costly, and there are barriers to obtaining that test for many of our patients. So to conclude about their findings, the use of a contrast washout on CT can miss malignant lesions other than ACC, and a density threshold of less than 20 Hounsfield units pretty reliably excluded malignancy, including things other than adrenocortical carcinoma. So I suspect you will see that get put into the American guidelines in the next iteration. Okay, our next question to talk about is adrenal metastatic disease. So I had the privilege of being part of this study group led by my colleague at the University of Pennsylvania and looked at patients with known history of malignancy. You can see that the majority of those patients had a non-small cell lung cancer as their primary tumor, and the majority had metachronous disease. So they've been at least 6 months since their initial diagnosis. And what we found is that resection conferred a survival benefit. So that was true in terms of disease-free as well as overall survival. 1 year was the greatest benefit, but then there was still a survival benefit even at 5 years. And so you can see that there was a difference between the patients with lung cancer primary versus those with a non-lung cancer primary. Those with a lung cancer primary actually tended to do better and have better overall survival. And so what we have come to recommend is that you should make this diagnosis and follow these patients with PET CT, but that you don't necessarily need to do a biopsy unless this patient is not a good candidate for surgery. And so that has now been incorporated also into the American guidelines, that an adrenal hormone evaluation should be performed in everyone with an adrenal mass, regardless of their extra-adrenal malignancy history. That in the setting of a radiographically indeterminate mass, biopsy should rarely be performed. And we already do this related to adrenocortical carcinoma, right? We shudder to think about biopsying an ACC, but we do this all the time for patients that we suspect may have a metastasis to the adrenal gland. And I think what we're saying now is that these patients benefit from surgical resection. So if they have oligometastatic disease, if this is their only disease site and they're a good candidate for surgery, don't biopsy it, just take it out. If you do biopsy it, God forbid, get metanephrines first. I have to say that. I'm in a room full of endocrinologists, right? And then lastly, resection may be offered to some select patients to improve survival compared to systemic therapy alone. Okay, on to the functional question. We'll spend the majority of our time here. This comes from the older version of the guidelines from the European Society, but about 25% of adrenal incidentalomas have been found to be functional. I think there's increasing evidence. You can debate which study you look at as to the actual prevalence, but I think that's a nice round number to use. And so, tears are made of salt. So if we think about aldosterone, we've got to think about sadness. And sometimes when I think about hyperaldosteronism, it does bring sadness to me for a couple of reasons that I will point out. So first, it's very much underdiagnosed, at least in the States. So we think about 15% of people with hypertension have hyperaldosteronism. That is a staggering number of people. And we are not making this diagnosis. The second reason it gives me some sadness is that we used to sort of think we could just put these people in two buckets. They've got an adenoma or they've got hyperplasia. And we now know that that is really not the case at all, that there's really this spectrum of disease going from micronodular hyperplasia, macronodular hyperplasia. Maybe you have one adenoma and it's small. Maybe you have an adenoma and it's big. People can have more than one of these things, anything in between. And so it's made the diagnosis a little bit trickier. I'm trying to borrow a British phrase. Please tell me if I got it wrong, but with a tricky wicket. And so this is the new algorithm for diagnosis of primary hyperaldosteronism. And we've really tried to adopt this in our practice, focusing around, is the renin suppressed? Is it lower than the reference range? And if so, what is the aldosterone relative to that? And you'll see right there in the middle, we used to say if their aldosterone is not more than 15, it's probably not primary aldosteronism. But now we're doing a lot more confirmatory testing for patients in this middle range with an aldosterone of 5 to 15. This is nanograms per deciliter, just in the event your units are different. And so we're doing a lot more confirmatory testing and potentially intervening on some of these people. But the third reason it makes me sad, I don't have a nice bubble to pop up, is that these patients largely get adrenal vein sampling. And we were having a nice discussion yesterday that here at the Hammersmith, you have these wonderful radiologists that get it right nearly every time, and we do not. I was checking on a result a little earlier today, and I had yet another AVS that failed. So that's another reason for sadness in my book. But if you do manage to secure a diagnosis of a unilateral source for aldosterone, then a minimally invasive adrenalectomy is recommended, as the majority of patients with primary aldosteronism have either complete or partial clinical success, and we define that similarly using the PASO study criteria. It is important how long the patient has been hypertensive. 5 years is where I start to counsel them. If they've been hypertensive for 5 years or more, telling them they probably won't come off of all of their medications. But most people will see a reduction in their medication doses post-operatively. We also know that it will decrease comorbidities. So fewer heart attacks, strokes, kidney disease, death. In the US, lower costs, and then an increase in patient satisfaction and well-being. Okay, your cortisol is kind of making you hyper aware of who you are, amping you up a little bit, so you're sort of aware of how exposed and vulnerable that you are. And I am not going to go into as much depth about this as usual, because I know we're having an entire talk about this immediately to follow. But I wanted to highlight just a couple of things. That patients, and I'll touch on 3 things. The next talk is just about MAX. So this is the only thing I have to say about that. 2 things. If you have mild autonomous cortisol secretion and it's from a unilateral adrenal nodule, then that person should undergo minimally invasive adrenalectomy because of anticipated significant improvements in cardiometabolic morbidities. We used to be much softer about this and fret and say, is this patient a good candidate for surgery? Will they benefit? What if their hypertension is very mild? What if they're only on one agent? What if they're a pre-diabetic? And I think we've really softened on that. And, I'll borrow Dr. Chen's analogy about primary hyperparathyroidism and treating it like diabetes, right? If a patient has diabetes, you don't wait for them to develop renal disease. You don't wait for them to develop neuropathy in their fingers or for them to go blind. You intervene early. And I think the same is true, or increasingly true, for myoautonomous cortisol secretion. The next are the patients with bilateral macronodular hyperplasia, and we see actually a fair number of these in our center. And really, we should be doing unilateral surgery for these patients, at least from the beginning, because that can result in biochemical normalization in 84 to 100% of patients. It's likely not durable over time, but it can buy them some time where they can be steroid independent. And then lastly, patients that have moderate or severe ACTH dependent hypercortisolism, if they are refractory to medical management or to, pituitary source control, they should undergo bilateral minimally invasive adrenalectomy. I wanted to give a plug. I didn't put his picture on the slide. I'm very sorry. He's here in person, to our fellow, Dr. Peter Abraham. He has this meta-analysis ongoing that he's talked about, but similar to other findings in this updated view, we have comparing surgical to medical therapy, 21 times odds of improvement in hypertension, 11 times odds of improvement in diabetes, 6 and 4 times respectively improvement in obesity and dyslipidemia. The great benefits to be had for patients that have adrenalectomy for MACs. Okay, on to our anxiety-producing pheochromocytomas. I think this is true for surgeons. It's perhaps more true for anesthetists that are working with us. I'll just touch on a couple of points. We want to see a plasma or urine metanephrine 2 to 3 times the upper limit of normal in order to feel comfortable that this is truly a pheochromocytoma. We do tend to block the patients typically first with an alpha blocker and then a beta blocker. I was very interested to hear yesterday that you all have easy access to phentolamine, because we absolutely do not. I had to sign away my firstborn child to get it for one patient. But anyway, we can talk offline about the agents that we use. I don't know who in here, I won't make you raise your hands, but when I was in medical school, I was taught the rule of tens about pheochromocytoma, and we now know that that's just complete rubbish. And that they have really the highest heritability of all adrenal tumors. And so genetic testing is recommended for everyone. And so to harken back to the guidelines, we want either selective or non-selective alpha blockade. There's no difference in morbidity or mortality depending on which type you choose. The selective blockade, you have a little bit more intraoperative hemodynamic instability, but with non-selective blockade, you have a little more postoperative hypotension. So we tend to err on the side of selective blockade, manage intraoperatively with clofidipine, and you'll see coming up, patient does well, discharge them the same day. We should also consider cortical sparing adrenalectomy in patients with bilateral lesions if it's technically feasible to avoid steroid dependence. And there's a bit of equipoise between the rates of steroid dependency versus the rate of recurrence. So I think that means that we have to have very careful shared conversations with patients. So if we put all of our hormones, all of our emotions together, then it makes me very sad looking at this slide, because it really needs a third question. But we have 2 questions to answer according to our European colleagues. Malignant, or is it functionally active? I wanted to show you sort of this is the protocol that we use in our center. I'm not going to go through it one by one because I've sort of done that already. The other thing that we do for every patient that we're concerned may have cortisol excess is we check an ACTH and a DHEA sulfate, as that can help us feel very confident about the diagnosis. I wanted to maybe, expose our soul and talk about how well we perform, because I can come here and say all these wonderful things about the workup that we do. And the truth of the matter is that in many cases, patients are found to have an adrenal lesion and nothing else happens. So this is a series from Boston, and I'll point your attention to the middle of the slide. They were looking at if you had an in-house primary care physician versus an outside primary care physician. It turns out it doesn't matter at all. And most people in the 20-ish% had some sort of follow-up imaging, and only 15% got the indicated hormone evaluation for an adrenal incidentalloma. We'll move to the opposite coast, to the University of California at Davis, and they found pretty much the exact same thing. Only 17% had hormone evaluation, 40% had repeat adrenal imaging. So we recognized that this was a problem, and we wanted to be able to do something more for these patients. And we've talked a lot about technology recently. So we helped with, our radiology colleagues had reached out to us to inquire about what do we do for all these patients with adrenal incidentalomas. And so we worked with them to develop a natural language processing algorithm. We scanned radiology reports for adrenal plus any of the words we might use. We had size limitations, we excluded subcentimeter, and then it was triggered if the patient had had a study within a specified time period. And then all of that got added to a registry, and patients were screened, and we excluded anyone that had, metastatic cancer, severe comorbidities, if they were already being followed for this by another person. And then if they weren't excluded, then they were offered an appointment to our clinic. So beforehand, you'll see that we were equally bad. If you look at the last row, our laboratory evaluation rate for patients with adrenal incidentalomas at UAB was 13%. And then after this was implemented, it went up to 99%. And our adrenal-specific imaging rate rose from 11 to 56%, still not perfect, but a work in progress. And 90% of people were seen within 3 months of their initial scan that triggered the protocol. I'll just touch very briefly on adrenal surgery, that both the American and the European guidelines agree that an R0 resection, where you do not violate the adrenal mass, is of the utmost importance. I tell our fellows that we treat every operation like it is a cancer operation. And that your choice of operative approach should be based on your certainty with which you can accomplish that goal, but that a high volume adrenal surgeon, so someone that does 6 or more operations per year, is important to improve outcomes. And one thing I will highlight where we deviate from this diagram taken from the European guidelines is that it says, if it's not locally invasive and the diameter is less than 6 centimeters, definitely go for MES. If it's 6 centimeters or more, then you individualized surgical approach. We're pretty aggressive about a minimally invasive approach for even very large adrenal lesions. I think I took out a 16 centimeter benign mass minimally invasively, but really trying to push that envelope. We do the full gamut of adrenalectomy approaches. Both of these approaches from both a laparoscopic and a robotic approach. And then I wanted to touch just briefly on outpatient adrenalectomy. So we have a few papers that relate to this. You'll note that in this particular cohort, about half of the patients had a same-day surgery operation, so had adrenal surgery that day, went home that night. This was not a randomized study, so the outpatients were more likely to have non-functional tumors and the operation terminated earlier in the day. But importantly, outpatient adrenalectomy was not associated with either increased readmission rate or complication rate. We also looked at the cost-benefit analysis. It's important for us to do in the United States. We have these two, matched cohorts from a quality improvement database. Important for us to say there were no differences in their outcomes. But that last line, there was cost savings of between $1 to $3 million for outpatient adrenalectomy compared to keeping the patient in the hospital. That study was done by our former fellow, Jessica McMullen. You'll see the breakdown of the diagnoses in the pie chart, but they span every type of adrenal surgery indication. And you'll note that the only thing different between these two groups was the length of stay, that there were no differences in composite morbidity or readmission, and that the sensitivity analysis favored outpatient over inpatient adrenalectomy. Lastly, Jessica Fazenine, whose face you've also seen before, published this framework for assessment and institutional protocol that patients have any of these factors, then we would not consider them for an outpatient procedure, but would rather keep them in the hospital. The bottom line, Non-contrast adrenal CT is likely the best imaging modality for ruling out malignancy. There is improved survival with adrenal metastasectomy, so we should likely be doing these operations more often. There's an increasing prevalence of MACs. We need to be on the lookout for that. And adrenal surgery is safe and can effectively be performed on an outpatient basis, even for functional tumors. So I hope I haven't given you adrenal fatigue, and I'd be delighted to take any questions. Thank you.
Thank you. Can I ask you about the definition of high volume surgeon? So for thyroid, we heard more than 25 to 30, and then for adrenal, it drops to more than 6.
6.
Yeah. Is it more difficult to operate on the thyroid, or is it, why is there a difference?
Yes, it's an important question. I think it relates primarily to volume. So if there are not as many adrenal nodules that need resection as there are thyroid nodules that need resection. And so there, the people that have done these studies demonstrate, there is a cutoff in outcomes with improved outcomes if you've done 6 or more per year. I suspect that that's a continuous phenomenon, and that if you were able to pull out the people that do 25 or more a year, you would continue to see their complication rates go down, but you wouldn't be able to do the study because you wouldn't have enough power. Because in the US, there are probably about 20 surgeons that would meet that definition.
Thank you. Just to answer that question, which Professor Platzer has been very modest about, the 6 came from the study you led on, and it was, you couldn't drill down lower than that because you could then identify individual surgeons. But if you stopped surgeons doing 5 or fewer, then actually all the other surgeons would be doing many more. And clearly, the more you do, the better you are. So those who were doing very few did very few, and then it was something like 20 plus a year faster. Yeah. Thank you. In Cardiff, we have similar difficulty in cannulating the right adrenal vein. In Cambridge and now Barts, they've been doing some really good research with etomidate. I don't know why we still haven't got it available anywhere else, but that's the dream. And then just a question, really, and I suspect it's language across the pond. America has very unfortunately introduced surgery as a noun. So we now hear our younger colleagues talking about surgeries, which puts me into an apoplectic fit. And I just wonder if the same is with oligo. So for us, oligo is a few, mono is one. So somebody really clear, we would only do a metastasectomy if there's evidence that is the only metastasis.
No, when I say oligo, I mean oligo. So if it's similar to you, and I agree with you, I always use the term operation and not surgery, and that is a hill I will similarly die on. However, I don't know that anyone has truly defined oligometastatic disease from widely metastatic disease, but in the papers that we based our study on, if a patient had more than 3 lesions, they were excluded. So they had to have 3 or fewer sites of metastatic disease to qualify as oligo.
Okay, so there was a European study a long time ago led by a guy in Barcelona, and we contributed to that. And what we clearly demonstrated was that the only benefit in a metastasectomy is if you get an R0 excision, as you were saying. So why would we getting an advantage with an R0 if there's other metastatic disease in the body?
Yeah, it's a great question that I don't have a clear answer for because I don't know that we understand the mechanism. I will say in patients that had 2 sites of intra-abdominal disease or patients that had an adrenal focus plus a pulmonary focus, those were sometimes resected simultaneously. And so those patients then became no evidence of disease. And I suspect that some of that survival benefit we see related to that.
Okay, so I've got a question that we'll take from the online that will probably lead on to Florin's talk. Now, the European guidelines talk about management of medical versus surgical for malautonomous cortisol secretion. From your talk just now, it sounds very much like you're advocating that we should actually be pushing Max for surgery. We've got a few questions here that are asking about what the evidence are in terms of Max improving CVD and life expectancy. Wondering if you could comment on that or whether Florin would like to take that one.
I don't want to preempt your talk. I'm not aware of any study that has been able to go forward and look at, cardiovascular disease, life expectancy, I think for two reasons. One is that MAX as a unifying diagnosis has not been around for a long time, so we just don't have long-term information. And the second is that, as we've discussed repeatedly, we're going to need the Scandinavian countries' data because there's no database in the US, at least, that would be able to answer that question. I don't know if
in terms of medical management, I suppose, is that something that you will look into in terms of incorporating in the guidelines?
I'm sorry, can you say
in terms of medical management for MAX versus surgical? Obviously, the European guidelines talks about this, but the American guidelines don't.
Yeah, well, in fairness, the American guidelines are guidelines for adrenal surgery. So they're not meant to be as expansive as the European guidelines. But I think, yes, we would love to have level 1 evidence if that were available to us. But if I put myself in the shoes of the patient, right, then I would like to choose the therapy that has the highest association with an improved outcome, even if I can't directly tie that to my risk of dying.
Good point. Thank you. All right. Well, I think we've run out of time. Thank you very much for a fascinating talk.
Thank you.
Okay, I'd like to introduce our next speaker. Most of you know him, Dr. Florin Vernick, who's one of the consultants here at the Hammersmith Hospital. And he's going to talk to us about the new approach to malautonomous cortisol secretion.
Right, okay. You ready? Beyond. Next slide on that will be the you want to do is the alt tab. So there, and then if you press go, it'll go to it. Okay.
Thank you very much. Thank you very much for Professor Palazzo for the kind invitation. You don't get to choose the titles. It's saying to Dr. Cox earlier. So it's supposed to be about a new approach in to mild autonomous cortisol secretion. And as my previous speaker alluded to, it's a relatively short history. So this was about 45 years ago, the first description of mild autonomous cortisol secretion. So a patient with no clinical features of Cushing syndrome had an adrenal nodule on imaging and failed to suppress the dexamethasone suppression test. And everything improved afterwards. So this was published in 1981. So why is it important? We heard already that it does increase the risk of metabolic syndrome, the risk of diabetes, hypertension, dyslipidemia. There's an increased fracture risk of about 1.5 to twofold. And also some cardiac abnormalities such as atrial fibrillation seem to be more common compared to people who don't have mild autonomous cortisol secretion. And the previous speaker also alluded to the European guidelines, and this is a diagram taken from the European guidelines. I mean, we've only got two questions, imaging and functionality, so the two columns. And I'm going to concentrate on functionality. And it is recommended in those guidelines that any patient with an adrenal incidental loma should undergo 1 milligram dexamethasone suppression test. And if the test is abnormal, we should assess for features of clinical features of Cushing's syndrome, and then assess comorbidities, which are potentially attributable to cortisol excess, such as hypertension, type 2 diabetes, dyslipidemia, and osteoporosis. And then the recommendations leave the interpretation open to discussions. It is, you should individualize treatment, the treatment decision, adrenalectomy versus medical follow-up. And we are left without much guidance for that. And I hope I'll manage to take you through some of the evidence we have now. So I would like to start with the case. So this is a lady with 64 years of age, 8 years history of hypertension on 2 antihypertensives, losartan and verapamil. She has diabetes and then an elevated body mass index. And the cortisol following an overnight dexamethasone suppression test was 115 nanomoles per liter, so clearly abnormal. ACTH was not particularly suppressed, but just perhaps the lower end of normal. Normal 24-unit free cortisol, normal late-night salivary cortisol and cortisone, a low DHEAS, and a normal bone mineral density on DEXA. And the imaging, as you can see here, shows a 2.5 centimeter wide adrenal mass with indeterminate pre-contrast Hounsfield units. And now I need to listen.
Ask the audience there.
Yes, so what would you do? It's 115 actually, the cortisol.
Okay, apology. Yeah, it's in. Just get everyone to vote.
There's necessarily a right and wrong answer. So the answer may be different after the previous talk.
Want to reveal?
Yeah.
Okay. Let's
Okay, so this is interesting. This is the UK perspective, I think. So there's treat comorbidities and continue imaging surveillance because it is an indeterminate mass. But also a large proportion now voted for unilateral adrenalectomy or medical treatment with cortisol-lowering medication. Yes, thankfully no one voted for bilateral adrenalectomy. And,
there's 2 more cases.
There's 2 more cases, yeah. Oh, yeah. I'm sorry. Yes, I can't do that.
Okay, we're going to repeat this, but with a different case. Yeah, so that's all done. This is case number 2, and then you can.
Yes, so this is a slightly different scenario. If you heard about bilateral disease, a patient with 53 years of age, female, hypertension on 2 antihypertensives, some physical signs of hypercortisolism, and a clearly abnormal overnight dexamethasone suppression test. The more severe disease, but normal bone mineral density and bilateral benign adrenal lesions. So what next? Okay, so let's keep up. All right, this is interesting. So 17 people put in unilateral laparoscopic adrenalectomy, and the majority actually voted for medical treatment with cortisol-lowering medications. And the third scenario, which is perhaps the other extreme, 54-year-old man with hypertension on losartan, and diabetes, and a hugely abnormal cortisol on following dexamethasone, especially 650 nanomoles per liter, elevated UNF3 cortisol, abnormal late-night salivary cortisol and cortisone, and low DHES. And the imaging shows bilateral nodular adrenal masses. What would you do with this patient? It's the same options, just to keep it simple. Okay, in the interest of time, I'm going to reveal that. And yes, it's an interesting spread. So the majority would either perform a bilateral adrenalectomy or medical treatment, and some voted for unilateral adrenalectomy. Minimize that. Yeah. Right. So the guidelines say test everyone, but when should we not test for MAX? We should avoid it if patients are unlikely to benefit from surgical management, or when the surgical risks would outweigh the benefits. And that is if patients are frail, or their life expectancy is less than 2 years, or they are on current oral glucocorticoid therapy, because there would be a risk of false positives potentially. The exception would be if patients have got overt Cushing syndrome, if this is strongly suspected, and there might be a feasible surgical option after an MDT review. And testing for MAX is sounds simple. So 1 milligram of dexamethasone at 11 o'clock at night, and we ask them to come back for cortisol the next morning. And if the cortisol is less than 50, then they are normal. But it's not that simple. So if it's abnormal, there's a recommendation developed for Cushing syndrome. And other tests such as late-night salivary cortisol, cortisone, or 24-hour UNF3 cortisol are not that helpful in the context of an adrenal cortisol hypersecretion. It's important to determine which patients truly have autonomous cortisol secretion, because the mortality seems to increase with increasing cortisol levels. And this is a retrospective 13-year study looking at non-functioning adrenal adenomas, so with cortisol levels of less than 50 after dexamethasone, 51 to 138, so possible max, and definite max more than 138. So this was the definition in this study, and this was later incorporated in the last edition of the guidelines. And you can see that the mortality increases with increasing cortisol levels. And again, back to the Scandinavian studies, there is an association between mortality and the levels of cortisol secretion by adrenal instantaneous. And this study found that there seems to be a linear relationship for death and cardiovascular disease in patients with an adrenal instantaneous and autonomous cortisol secretion. And what they found is that a plasma cortisol level of more than 83 nanomoles per liter or higher is associated with a 2 to 3-fold increased risk in mortality. So you can see this here on this Kaplan-Meier curves that the mortality significantly increases once cortisol is more than 80 nanomoles per liter. And by the way, this is all-cause mortality, not just cardiovascular, but also mortality from cancer. However, again, it gets more complicated, because this excellent study by Alessandro Prete, one of our colleagues from Birmingham, actually showed that even patients with so-called non-functioning adenomas seem to have a higher cardiovascular risk than patients without adrenal adenomas. It suggests that even subtle autonomous cortisol secretion is important. So I like this new concept, and this fits with the title, the new approach to mild autonomous cortisol secretion, that actually we should consider this as a continuum rather than a strict cutoff of 50 nanomoles per liter. And what you can see here is that with increasing cortisol levels in pink, the cardiovascular risk increases, various ACTH levels and DHEAS levels do decrease. What it also shows is that the transition to Cushing's syndrome, so that Cushing's syndrome is exceedingly rare. So is it time to lower the cutoff for the overnight dexamethasone suppression tests? And this is a question that's actually being asked. And for physicians, it's not that simple actually to just consider a cutoff of 50 nanomoles per liter, because the overnight dexamethasone suppression test is prone to quite a few false positive occurrences. So, for instance, non-compliance. So the test is normally carried out at home. Have patients taken it at the right time? Have they taken the tablet at all? Is it absorbed? Do patients take other medications that induce liver enzymes? Or is cortisol binding globulin increased due to exogenous estrogen, etc.? Or is it due to stress or pseudocushings or patients with obstructive sleep apnea, for instance? And there's also other considerations, which means we have to know our local assay. And some cortisol assays do read lower. And it's been suggested that, for instance, for the alkalinity assay, the cutoff should be lower to 31 nanomoles per liter. And there's also a suggestion that age, the renal function, and the BMI should be taken into consideration. I saw that that our American colleagues also measured dexamethasone, which does reduce the false positive risk by 20% and improve the specificity. This is a study carried out by Grete Ulam from Norway, who showed that simultaneous measurement of dexamethasone with a cutoff level of 3.3 nanomoles per liter or more is sufficient for the suppression of cortisol less than 50 nanomoles per liter. We tend to do this regularly now, and for people who work in Northwest London, so you'll be pleased to hear that hopefully this will soon be a routine thing to do, a routine measurement. So whenever one requests an overnight dexamethasone suppression test, and the cortisol is more than 50 nanomoles per liter, dexamethasone will be added automatically. So how do we interpret other markers such as ACTH? And it is, again, if the ACTH is fully suppressed or less than 10, this supports an ACTH independent cortisol excess. But this is not always the case. And ACTH of more than 15, if this is the case, we need to take into account ACTH-dependent excess or pseudocushings, for instance. It is important not to measure ACTH after dexamethasone, so we can't do this at the same time because it would be suppressed. And it's better to use a range rather than a cutoff. There are certain other caveats, such as high-dose inhaled glucocorticoids that may suppress ACTH. And we shouldn't use just a single ACTH to determine the need for adrenalectomy. And as you can see here, even in large series, patients with confirmed MACs have relatively high ACTH levels intermittently. To make this more specific, we can use adrenal androgens and measure DHEAS. And Professor Gannell and this group in Cambridge showed in this very nice study that actually the low DHEAS has a very high sensitivity and specificity to detect subclinical hypercortisolism. And it should be used in conjunction with ACTH measurements and should not be used in isolation. Again, it must not be measured after dexamethasone because it would be suppressed. Right, so once we've got the diagnosis that patients actually have mild autonomous cortisol secretion, what do we do? And the guidelines so far, at least the European guidelines, do not commit to either medical treatment or surgery. And it seems to be perfectly acceptable to discharge patients back into primary care with a cortisol level of less than 80 nanomoles per liter. and optimize medical management and with clear instructions to the primary care physician. And that's what most people would do. Unilateral laparoscopic adrenalectomy. There's more and more evidence, and I'll talk about this in a minute, that actually patients may benefit, but as someone correctly commented, we don't have any data on improved mortality. And cortisol-lowering medical therapy is off-label and can be selected for can be used for selected patients, but the evidence is even less than for adrenalectomy. So the decision should be influenced by patient preference and patient characteristics, the degree of cortisol excess, cardiometabolic burden, and also adrenal imaging findings on CT or MRI. Right, so back to case number 1. So many of you voted for medical management. Some did vote for an adrenalectomy. And this patient actually was involved in a study led by Professor Bergenfels from the University of Lund, and we were one of the centers with Professor Palazzo participating and myself. And patients were randomized to either adrenalectomy or medical management and followed up for 2 years. They had 24-hour blood pressure monitoring every year, echocardiograms, bone density scans, etc. And so this patient was actually randomized to adrenalectomy, and Professor Palazzo carried out an laparoscopic adrenalectomy in 2023. And what you can see here is the sustained weight loss up to now, actually, of about 10 kilograms following adrenalectomy. In addition, this patient remains normotensive, managed to stop both antihypertensives. And you can see here at the 2-year follow-up, the 24-hour blood pressure reading with an average blood pressure of 126 over 69 millimeters of mercury. So a really excellent result, but this is one patient. So this was published earlier this year, actually. And so these were the results from the study. So 33 patients were included in the study, randomized to either adrenalectomy observation, and there was an improvement in blood pressure and glucose metabolism in the surgical group. So 2 years, 9 out of 12 patients who underwent surgery, their hypertension improved and they used less antihypertensive medications, whereas less in the conservative group. Unfortunately, we did not quite reach the target of patients we wanted to recruit due to COVID, etc., and other factors. Another trial was published earlier this year, and this study had the advantage that actually the antihypertensive treatment was standardized. So there was an initial phase when patients were recruited that all antihypertensive medications were stopped. And then in a standardized stepwise approach, they were restarted. So everyone was at the same point, and then they were randomized to surgery or medical treatment. And this study had similar results. It found that there was a reduction in antihypertensive therapy with normal home blood pressure in 46% of patients after adrenalectomy versus 15% patients of the conservative group. So all in favor of surgery, really. However, what I said earlier, from what we know from the data so far, so from the retrospective studies, it seems appropriate to offer patients conservative management if they have very mild autonomous cortisol secretion, so with a post-dexamethasone cortisol level of 50 to 80 or 30 to 80. Well, or minimal comorbidities, and also if they are frail, or the benefit would be not in their, or they probably wouldn't benefit from surgery because of that. Surgery is favored when they have resistant hypertension, progressive diabetes, vertebral fractures, osteoporosis, or higher cortisol autonomy. And medical therapy, as I said, we don't have much evidence. There's studies ongoing now to restore circadian rhythm with osilotastat, once daily osilotastat, for instance, so we need to wait for the outcomes of these studies. So case 2, we heard already that many colleagues will perform a unilateral adrenalectomy, and the evidence is limited, and management again must be individualized. So we should optimize medical care for comorbidities, but unilateral adrenalectomy in selected cases seems very reasonable. The question is which adrenal to remove. Subtotal adrenalectomy is rarely performed and not really recommended, and cortisol-lowering medical therapy, again, we don't have much evidence about the long-term outcomes. But we know that bilateral disease carries a higher comorbidity burden. And we also know that cortisol overproduction will likely persist or recur even after surgery. And medical therapy may therefore have a larger role for those patients. Which adrenal to remove is an ongoing question. So pragmatically, we would often choose the larger gland, or the larger lesion, I should say, because there's not much evidence for AVS or functional imaging, such as cholesterol imaging, which we used to do in the past. And it's not validated for MACs. And we have done it before, but it should only be considered in very selected cases. There's more and more emphasis on genetic testing, and I'm going to talk about this in a minute. And the treatment response should really prioritize clinical outcomes over biochemical cure, which we probably won't be able to achieve in the long term. What is really important that decisions are made within an MDT with surgical expertise in MACs and adrenal surgery. And the MDT should include endocrinology, surgery, radiology, and often also an anesthetist, in particular if we have to make decisions about frailty of patients. We alluded to that surgeries should be carried out in high-volume centers, and this is Professor Platzer's publication from 2016 that was suggested that the outcomes are much better if a surgeon carries out 6 adrenalectomies per year or more. What is also important, and I saw this in the algorithm my colleague, the earlier speaker, showed, to confirm actually persistent MACs, because a minority of patients actually normalizes over time. And so it's recommended to repeat the overnight dexamethasone suppression test and also to repeat ACTH measurements, and to do another assessment just before surgery to reduce the false positive rate. So case number 3, it's not really MACs. I mean, this patient has Cushing's syndrome. It's a very high 24-hour urinary-free cortisols, everything abnormal. And the CT adrenal shows bilateral macronodular hyperplasia. So this is a patient from one of my colleagues from St. Mary's Hospital who was at the audience. And in such a case, we should consider genetic evaluation, as there are certain conditions associated with bilateral adrenal masses and autonomous cortisol secretion or Cushing's syndrome. And we are more and more aware of RMC5 mutations, for instance, which is recommended in MACs and bilateral adrenal disease. And this particular patient actually was found to have a likely pathogenic mutation for RMC5. These are some genetic syndromes associated with adrenocortical tumors, such as Carney complex with primary pigmented nodular adrenal hyperplasia, MEN, but in particular also the macronodular adrenal hyperplasia with RMC5 mutations. There's other more rare diseases as well, and it potentially will make a difference to the patient's management and the patient's family. It is important to counsel patients about postoperative adrenal insufficiency, because there's a risk of transient adrenal insufficiency in MACs patients. So we tend to assess an early morning cortisol on day 1, because patients usually stay for at least 1 day after their adrenalectomy. And if there's doubt, patients are being discharged on steroids. And the day 1 cortisol is often difficult to interpret because patients are being given dexamethasone as an antiemetic, or they're on PCA and opioids for pain relief, and which can give rise to falsely low cortisol. They need to stay under endocrine follow-up until the HV axis has fully recovered. And this is the MIRAM protocol, which you can find on our website, on the Imperial Endo website. So if patients are discharged on steroids, it's really important to actively follow our patients up to actually reduce the steroid burden. This is a protocol patients can follow to reduce their daily prednisolone dose over the course of 6 months to 0. So in conclusion, MUX is relatively common in patients with adrenal incidentalomas, possibly much more common than we thought, in particular if we lower the cutoff. It's associated with multiple comorbidities and increased mortality. And the 1 milligram dexamethasone suppression test remains the main diagnostic test. And the results should be interpreted as a continuum. And I think that's the new approach. It's not just a single cutoff and then we discharge patients. It can change over time. And we need an individualized treatment approach. Surgery for selected patients may improve cardiometabolic comorbidities. And it's important to also assess patients for postoperative adrenal insufficiency. But some questions remain. So which patients will likely benefit from surgery long term? Because there remains uncertainty about causality of mild autonomous cortisol secretion and comorbidities. And it's difficult to predict which patients actually will benefit most. And we don't have any long-term data on mortality. We don't know how effective long-term medical therapy is, on the other hand. And again, data are lacking and studies are currently ongoing. But I agree with my previous speaker that why should we wait until comorbidities actually develop? Because we don't necessarily do this with other diseases. And should we actually treat before comorbidities occur? The other thing is the longer patients have mild autonomous cortisol secretion, the less likely it's going to be reversible. And with that, I would like to refer to the February Adrenal Study Day and would like to invite you to come and participate. It's on the 6th of February, a whole day dedicated to adrenal disease with the clinical science morning and some cases in the afternoon. Thank you.
Thank you. Thanks very much, Florian. Really excellent talk. Can I just start with a question? The trials that you've shown where you've compared surgery to conservative management for MAX, why have we not used a medical treatment arm as a comparator? Because if we're saying that surgery will treat the comorbidities, is there not an automatic bias here? Because I think that there's some studies from Sheffield also showing that giving metarapone late in the evening reduces hypertension. They didn't show improvement in diabetes and weight. But nevertheless, I think the fact that we went for no treatment versus surgery, you don't answer the questions about the benefits of medical treatment.
Yes, it's a good question. And this study hasn't been done yet. But yes, the Sheffield study was very, very short follow-up and really preliminary data. But there's a much longer study in process now. And I think we need more data. We haven't got enough data.
To continue to have a gap.
That medical treatment actually improves the long-term outcomes. And all the studies so far have just compared surgery to best medical treatment. But it's something that possibly should be done in the future.
Any other questions? We look online. Sorry? Oh, 1 minute.
Thank you. I just wanted to, well, firstly, thank you for your excellent talk. It was a wonderful follow-up to the one that I gave, and I think filled in a lot of details. One slide that I had taken out, and I sort of assumed maybe this audience would have seen it, but there are several studies, they tend to land in the radiology literature, looking at the relationship between size of adrenal adenoma and cortisol production. And so there's a pretty direct correlation that as an adrenal nodule increases in size, it is more likely to produce cortisol. So I felt very disappointed with your question about the patient with the bilateral adenomas because I really wanted to see which one was larger. Because I typically would recommend taking that one out, whatever side is larger. We've attempted to do adrenal vein sampling to determine, if one side is worse and compare it to catecholamines. That has been fraught with difficulty, as you had mentioned. I also, again, I'll make one comment just about the person with very mild disease, and we all have anecdotes, but I was privileged to operate on a patient that I wasn't very sure would benefit from surgery. They took one antihypertensive, their A1C was normal, their lipids were trending toward the higher side. They're 53, they run daily. And we had a long discussions, also a physician. And I offered her surgery if she wanted, but I told her I wasn't sure what benefits she would have. And I got a lovely email from her now that she is 3 months out. And she said, I now realize I was symptomatic. I had mild proximal muscle weakness, an 8-pound weight gain, 8 pounds, some changes to her face. And it was all gradual and subtle that she didn't recognize. And she now feels like she is herself again. And I think we don't often take time to hear or listen to these subtle symptoms. And so I would just, say that I agree that we need comparison studies to medical therapy from surgical therapy. But I think often the holdup is that we're concerned about the complications of surgery. And if you have access to a high volume adrenal surgeon, then I think that those concerns can be minimized. So
I'm not sure if Amy and Fausto will be pleased if we start sending all these patients to them.
Actually, we were just having a conversation about the MDT approach to these patients and how difficult it can be, because obviously the ones that stand to obviously benefit the most, the ones who already, as you know, Tricia, who we discuss in the MDT because they have a huge BMI, they're diabetic, they're hypertensive, and we roll our eyes and sigh because they're going to be difficult surgical candidates. But yeah.
Do you think there's a scope for doing like a dynamic test on them with medical therapy for a short space of time before surgery?
I guess there are two angles, aren't there? Also, the possibility that those patients may not get to that point if we start to believe the max data and intervene sooner. And whether your GLPs will also help us in the short term.
Can't access those drugs.
Well, yeah, okay, on the down low. We occasionally moan so much that Tricia and the team will advocate for a 6-month trial to see if that just helps us a little bit feel more positive about surgery.
It's interesting you mentioned the quality of life of your patient, because we actually did look at quality of life in our study, and there was no difference between the two groups. But yeah, it's small number. But I think we do consider surgery much more now because we have got these prospective studies actually showing some benefit in hypertension. Yes, all the evidence up to now was retrospective.
Agreed. Lauren, got a few online questions.
Yes.
I'll start with the first. Is there no need for a minimum? Oh, which one? Okay.
So, yes, the 24-hour urinary cortisol. I mean, it's helpful, but it's usually normal in mild autonomous cortisol secretion, because if it's elevated, then that's more in keeping with Cushing's syndrome. And what would we do if the dexamethasone level is less than 3.3? Yes, that's a good question. And would we use a higher dose? I mean, we need to be sure the patient has taken it and make sure there aren't any of those false positive factors I mentioned earlier. And the problem is higher dose dexamethasone is not necessarily validated, but I know that some people tend to do that, just give a higher dose, because as long as you measure the level, it actually should work. So this is not something we routinely do. We tend to repeat it.
Suppose you could target that dex level that you think your other patients suppress.
Yes, exactly.
No, but if you... It's the way you're metabolizing the DEX, isn't it?
And yeah, so the guidelines do not suggest that we need more investigations. So what it does suggest is to use ACTH and DHEAS, so renal androgens, as the additional test to diagnose mild autonomous cortisol secretion. You can replace. This is difficult. We don't know what's better, isn't it? But that's. No, I mean, it's not something we would recommend. This is something we would do for Wirth-Cushing syndrome, more as a short-term measure, but certainly not for MAX. Just one.
I think we covered overnight DEX.
Yeah.
Is there a negative association with CT adrenal negative Hounsfield units and cortisol oversecretion?
Not necessarily, no, but not that I'm aware of.
Okay, right.
Can I ask you something, Florian? Try to just one last thing. You're a great fan of radiofrequency ablation of the cons tumors. It looks like that's going to have a future. The question is, in 10 years' time, do you think, given that we are going to end up operating on lots of mild autonomous cortisol secretion because the data is starting to grow, that the metabolic changes justify surgery, do you think that in 10 years we're going to be thermally ablating mild autonomous cortisol secretion and electroporating mild autonomous cortisol secretion?
It's a very good question. It's actually a study we would like to do. The problem with that is that these lesions tend to be quite large. That may limit what we can do with thermal ablation. With larger tumors are more difficult to ablate. But in principle, it would be very attractive because you can also ablate multiple lesions.
Electroporation is attractive because you don't have thermal ablation is accompanied by necrosis and therefore the risk of infection and bleeding and so on. Because electroporation seems to be not, I won't say risk-free, but relatively has a better safety profile. So that might be a solution, and you can do it in a staged way. So you don't have to do it ablate the gland all in one go. You could do it on 2 or 3 occasions. I'm not trying to put myself out of work. But I'm just thinking that seems to be the direction of travel, as long as it's benign.
Okay, thanks very much, Florian. Okay, we're now going to move to the cases, and the first speaker is Dr. Churiwala. Thank you.
Good afternoon, everyone. My name is Jayati Churiwala, and I'm here to present a case of pseudo-hypoparathyroidism with the aim of generating a discussion in the House of the nuances in its management, especially of the debilitating complications that it comes with. Disclaimer here, it's going to generate more questions than I'm going to be able to answer. Rolling back to 2014, a 24-year-old female presents with severe hypocalcemia. Biochemical investigations show a corrected calcium of 1.6, a PTH of 124 on a background of normal renal function. The past medical history is significant for hypothyroidism, for which she's on levothyroxine, suffers from rheumatoid arthritis, for which she's on methotrexate and etocoxib, and also suffers from childhood epilepsy, for which she's on levetiracetam. On physical examination, there are no features of Albright's hereditary osteodystrophy. That seems to be a problem here. Kind of raises a suspicion of PTH resistance, not something surgeons are very comfortable with. Next step was, of course, involving the right people, the endocrinology team, and the geneticists. And they come up with a diagnosis surgeons have never heard of: pseudo-hypoparathyroidism type 1B, resulting from something called UPD20, which I'm afraid to even pronounce, but I'll try. It's uniparental isodisomy of chromosome 20. Now, what is this condition and what does it cause? Minusing and subtracting all the jargon from that slide, the important thing is the proximal renal tubules can only express a copy of this chromosome that comes from the mother. In this problem, either they receive 2 copies from the father or the maternal copy is not being expressed due to epigenetic mutations, which essentially means the proximal renal tubule is resistant to the action of PTH, but all the other end organs are responding normally to PTH. So we've known this condition for less than a century, but the first consensus statement of actually diagnosing and managing this has been around for less than a decade now. And the goals of management are quite obvious. You want to try and keep the calcium normal. You want to try and keep the phosphate normal. You want to try and stay in that upper normal range of parathyroid hormones and try and do all of this by using activated vitamin D and calcium supplements to avoid hypocalcemia. The important things here, though, are genetic testing and genetic counseling to see whether other family members are affected and whether there is involvement of other hormone systems, because some of these patients can have resistance to TSH and growth hormone as well. Problem with this guideline is it nowhere mentions the surgical management for this condition, and therefore endocrine surgeons don't know much about what to do when the patient has the problems that they come with next. So medical management works well for this patient up to 2023, where the corrected calcium starts to rise, and so does the alkaline phosphatase. An isoenzyme analysis reveals that the alkaline phosphatase is coming from the bones. A bone scan does not give us much except enthesopathy. And of course, the calci-2 and alpha-calcidol are withdrawn because the patients run into hypercalcemia. Problems only worsen over time as this patient makes their way to the right team. The corrected calcium goes up, alkaline phosphatase is high, PTH is over 200 now, and the bones start to show subperiosteal resorption in the phalanges and brown tumors. Time to call the jolly surgeons. This patient's referred to the Department of Endocrine and Thyroid Surgery at Imperial, and by this time, this patient is debilitated, not able to perform their activities of routine, activities of daily living. Their PTH is over the upper measurable limit of our lab assay. Patients discussed at the Imperial MDT, but I would like to know your opinion of what would you offer this patient? We all agree it's going to be surgery. Question is, what's going to be your approach? Are you going to opt for a preoperative localization and a targeted surgery for the parathyroid glands, bilateral neck exploration with either a subtotal parathyroidectomy or a total parathyroidectomy? And if you do opt for total, are you going to auto transplant?
Right, 10 seconds, everybody. Everyone. You can just click you.
Right, subtotal parathyroidectomy or parathyroidectomy with auto transplantation. Next question. Would you use intraoperative PTH? Irrelevant. That's the relevance. So when this case was discussed at the Imperial MDT, we unanimously agreed that this patient should be offered surgery, should be offered bilateral neck exploration, so we can see at all the 4 glands. Now, on the day of the surgery, unfortunately, this patient sustained a fall and developed a left neck of femur fracture. She was referred to the orthopedic team for acute management. A screening skeletal CT showed global affliction of the bones with multiple old heel fractures. She was discussed at the orthopedic MDT and underwent fixation for this fracture, and of course was referred back to us for expedited parathyroid surgery. We attempted a preoperative optimization as far as we could. We knew the surgery was urgent. At surgery, all 4 glands were identified in the neck and a total parathyroidectomy was performed. We did not perform a thymectomy. We did not use intraoperative PTH. On histology, all the 4 glands were affected by pseudoadenomatous hyperplasia, and the glandular weight ranged from 0.58 to 5.7 grams. Post-operatively, expectedly, this patient went into hungry bone syndrome, but this was closely managed with both calcium as well as alpha-calcidiol, requiring temporary IV calcium infusions. On post-op day 1, the PTH was 1.02 and she was discharged on post-operative day 10 with a calcium of 2.06. She's currently well and undergoing rehabilitation with physiotherapy. The most important part of this case is the pivotal role that a well-constituted MDT plays in managing cases like these, where experience is limited because of the rarity of the disease. Thank you very much. I'm happy to take any questions.
Any questions? Oh.
I might have misheard. Did you do a total parathyroidectomy?
Yes, without a thymectomy.
So where's the PTH coming from?
Thymus.
So the big question here was, yes, which type of operation? And I think what you have to realize, this girl has high PTH levels from about the age of 10 is normally when this cuts in. It's from about the age of 10. And so PTH is not working in the proximal tubule because the maternal allele is not being expressed. And that's because she's got 2 copies of the paternal allele. So she doesn't work in the proximal tubule, doesn't activate bit D. It does work in the distal tubule and it does work on bone. So since the age of 10, instead of going through her nice peak bone mass, she's got high PTH causing bone resorption. So she's like having primary apopara all the way through from age 10 to the diagnosis on the bones. So then you've got these enormous glands. And of course, the treatment for pseudo-hypopara is to give alpha-calcidiol. So she's going to be on that after the operation anyway. And then the question is, well, what's the guideline? The guideline is to get the PTH down into the upper part of the normal range. So we're aiming at a PTH of 8 or so, or maybe even 10 max. Her PTH was 350 just before the operation. So first, could any surgeon give you a result where you're going to get 10? I think that's a really tricky one to do. So my feeling was that's an impossible task. The second point is, if you leave any parathyroid tissue, she's going to have hungry bone syndrome like nothing else. Her ALK phos went up to 900 immediately post-op, and she's sucking in calcium because she's got 20 years worth of bone demineralization to make up. So because PTH is a calcium balance hormone, your PTH is just going to go up again. So any remnant that you leave will become hyperplastic again, and she'll redevelop disease. So I take blame for this. I made Fausta very uncomfortable. And myself, I was a bit, because I said, no, you've got to do all 4, take out all 4. We don't want any residual tissue. She's going to be on an alpha-calcidiol anyway, and I want her bones to remodel. And actually, can I just say, I have seen her latest CT scans, and it's fantastic. The ALK phos is now down to about 200, and the surgeons are absolutely delighted with the amount of new bone that she's made in that remineralized in the time. So, so sorry, I've given you a bit of a long explanation there, but yeah, if that answers your question.
Spot on. Yeah, I had the same problem, but I know my hierarchy.
Yeah. I'm already convinced. Can I ask about the terminology? When we talk about secondary hyperparathyroidism, we divide it into basically vitamin D deficiency and renal hyperparathyroidism. And most patients with renal hyperparathyroidism are normocalcemic. And no one in this room in 20 years has yet been able to tell me why some people with renal hyperparathyroidism become hypercalcemic. And then we have post-transplant inappropriate secondary hyperparathyroidism, which now is we call tertiary hyperparathyroidism. So is this tertiary hyperparathyroidism or is this hypercalcemic pseudo-hyperparathyroidism?
Jeremy, can I ask a question?
In there.
Okay, I'm going to ask another question quickly. Do you think there's a role for biphosphonates here, or denosumab, etc., sort of pre-surgery, for instance, to prevent the hungry bone syndrome?
I suppose I'm not meant to look horrified. I want this girl to remake bone. The last thing we want to do is shut that bone down with a bisphosphonate.
But would you actually have considered this if she wasn't actually in the earlier on of the course of her treatment? Was she on any treatment?
I think in the treatment guidelines for pseudo-hyperparathyroidism, bisphosphonates aren't generally in there. What you've got to do is control the PTH so that you don't cause the problem. Does that make sense?
Yeah, no, it's just in some of the literature, people do talk about sort of, shutting down the osteoclast activity.
Yeah, I mean, I think the main thing here is we were already, in fact, Fausto emailed me a few times. We were already worried about how quickly can this lady remake her bone when you've taken out all the parathyroid tissue. And because your bone formation rate is likely to be altered. So PTH is really involved in remodeling based bone formation. So when you've dug out all your nasty pits and you remake them, they actually remake to a greater extent. So as she repairs her skeleton, you want her to remake to a greater extent at each of the holes that she has made. And so, so we were a little bit worried. And if you had a bisphosphonate, you would really be shutting that down even further, the ability to remake your skeleton. So yeah, we did have quite a conversation about this. But I think our AltFOS tells us the answer. Up to a 900 now, but now down to 220 after a few months, doing fantastic.
Okay,
the thing is, surgeons come at this from a simplistic mindset, let's be honest. And so we think of it, or I did, as a tertiary hyperpower, like a renal patient. And we always think, if only we could just leave a little bit of PTH, because no PTH, there's always this thing about adynamic bone disease, and a little bit of PTH helps the bone turnover. So that's why with a PTH 1.2, I went off and, said, let's go and celebrate. That's why we don't take the thymus, because you think there might be just something in there when you found 4 glands. But I got an education, basically.
Can I just ask about the question that's on the chat there about why thymus are left behind if, as Jeremy says, PTH might come back? I don't ask that question.
That's a perfectly reasonable question, but I was following the orders. Yeah. So we said total thyroidectomy is the way to go, and I thought I just hope there's a little bit of parathyroid function, but it's illogical, really. But for mentally, it just makes sense. But you're right. I think there is a chance that it could come back.
you want to take the microphone so that the Zoom people can hear you?
That's a great question. I mean, I've taken the thymus out, and there's been, an enlarged gland in there, one of the four, or occasionally an additional functioning gland. So, yes, they are, but usually not the dominant one. So I tend to take them out for secondary, but not for tertiary, the thymus.
Just to say, I mean,
Take the microphone, yeah.
pH is not coming up. Okay, so it's just a tiny detectable, but it's not on its way. But it's a very good question, isn't it?
And does it mean that she might need a thymectomy in years to come?
I sort of doubt it.
Okay, thank you very much.
Okay, our next speaker is Dr. Carter.
Sorry? Use that, yeah? That's fine.
Hi, everyone. Good afternoon. My name is Keiko Carter. I came from South Wales. I currently work in the Royal Gwent Hospital in Newport. I am a IMT2, internal medicine trainee year 2. So I want to present an interesting case, primary bilateral adrenal lymphoma. Let's start. So 50-year-old gentleman came with quite a lot of symptoms, quite general, night sweats, weight loss, blue stool, low appetite, some cough, body ache, intermittent left upper abdominal pain, and low-grade fever. So we started general investigation. It's the background. His background is past medical history is asthma, type 2 diabetes, hypertension, hypercholesterolemia, gout. And he had a notably family history, neuroendocrine tumor. The first investigations, lots shows leukocytosis, normocytic anemia, and some elevated LDH. We performed abdominal ultrasound showing splenomegaly and metastatic inflammatory changes. So we still not sure what is going on at this point. So we performed the extended investigations. So we performed CT TAP, splenomegaly, mild colitis, no malignant seen, and autoimmune panels all negative. The other blood tests, ACE, including ACE, it was normal. Tumor marker CA1989 was negative. And also we did microbiology, extensive microbiology investigations. Most are negative, only EBV serology IgG positive, which suggesting past infection of EBV. And bone marrow biopsy also done, which was normal. And also including TB is minor infections all negative. And also we did echocardiogram, TOE, no vegetation, no signs of myocarditis. So at this point, we couldn't reach confirmed diagnosis. Possible mild colitis. After 4 weeks of admission, his symptom was settled. So we discharged him with follow-up plan. So 4 months later, he presented with similar symptom, anorexia, weight loss, fever, left upper quadrant, abdominal pain. So we repeated PT abdo-pelvis. So this time, just after 4 months, it was quite shocking picture we saw. Bilateral adrenal masses 6.7 centimeter right, 4.5 centimeter left, and also splenomegaly, which was seen last time, and HU was more than 20. He also developed hypotension, which resistant to IV fluids. So we suspected adrenal insufficiency, started hydrocortisone, and cortisone level was low, and we performed short sensitivity test, which confirmed adrenal insufficiency. And because of background of NET family history, we performed 5-HIAA, which mildly raised. It is still suspicion for neuroendocrine tumor. The further investigations, MRI showing bilateral adrenal masses, splenomegaly, and features suggestive of lymphoma or metastases from unknown primary. So we performed biopsy. The biopsy results showing diffuse large B-cell lymphoma. We refer to hematology team and hematology MDT discussions, outcomes as they said possible dural pathology, NET versus lymphoma, and they decided to start chemotherapy. And also endocrine team reviewed for primary adrenal insufficiency. We did all the hormonal panel, and then also he developed hypogonadotropic hypogonadism. We started testosterone replacement. So during the second admission, we got a confirmed diagnosis and a treatment plan, and followed up by endocrinology team and hematology and oncology team. Later, the oncology team reviewed, they said this is no evidence of neuroendocrine tumor. So he completed chemotherapy that suggested by hematology. And 4 months later, is clinically and biochemically improved, and adrenal mass size is completely gone, and however, adrenal insufficiency was persisted. So this is the imaging after 4 cycles of chemotherapy. So adrenal mass has gone, splenomegaly is still there. So it was resolved, and still she is under monitoring and under hematologist. So from this case, what we learned, first, primary adrenal lymphoma is really rare. However, this is quite aggressive and can present with bilateral adrenal masses and adrenal insufficiency. The early recognition and treatment of adrenal insufficiency is essential because this is a life-threatening condition. When patients with constitution symptoms and adrenal masses, we should suspect for primary adrenal lymphoma, and prompt initiation of steroid therapy and with chemotherapy is crucial for this case. Thank you very much.
Thank you very much. Very nice presentation. Any questions?
What an interesting way to diagnose primary adrenal insufficiency. I think whenever you make that diagnosis, I like to look back and say, who first thought of that possible diagnosis? Because they're the ones who deserve a medal. It's so uncommon in our practice, and even more uncommon in their practice. It's almost never the endocrinologist. Sometimes it's a GP who thinks, oh, could this be? Or a gastroenterologist or a biochemist. Here it was a radiologist who gave it to you, in a sense, by showing the adrenal masses, so nobody gets the medal, really. Have you been back to ask, no, have you been back to ask whether adrenal insufficiency could have been diagnosed at the first presentation? Were there sufficient clinical features, were there sufficient biochemical features to suggest that that might have been diagnosable then? Because he had weight loss, and he was jolly unwell, and he was in hospital for 4 weeks, and he had a lot of saline, I guess, and went home feeling better. What were his electrolytes back then? Do you know?
Yeah, this is quite summarized quite shortly, this presentation. So the patient presents with like B symptoms, fever, anorexia, and weight loss, and then he got hypotensive, and then we usually do hypotensive patients resistant to IV fluid. We proceed cortisol level, the suspicion of the. So I think in this case, and also I didn't show this one, the hyponatremia and hyperkalemia. These like biochemistry showing adrenal insufficiency. So that's why, and then we immediately started the hydrocortisone.
Thank you. Any other questions? Okay, if not, thank you very much. Okay, our final case is from Dr. C.
Later, yeah? Okay. Do that. Yeah, do the switch.
Sure. Okay. Hi, good afternoon. I'm welcome to the last case report of today. I'm Madeline. I'm one of the medical registrars at Chelsea and Westminster Hospital. And together with me working on this project is Iman, who's sitting there. She's our endocrine registrar as well. We're delighted to be here and honoured to present an interesting case report we find, and hopefully it will echo with some of the topics that we had earlier today by our prestigious speaker as well. So before let's start. So a diagnostic puzzle, hypercalcemia and hyperprolactinemia in a young woman. She was a 37-year-old lady was presented to A&E last year, July. She had chest pain, breathlessness following a recent extensive bed rest for her migraine. She's got background of previous PE, primary hyperparathyroidism, and previous parathyroidectomy back in the States, migraine and chronic Lyme disease. She doesn't take any regular medication, and we diagnose on CT that she has acute PE. Incidentally, on her blood test, we notice she's got high calcium level at 3.20 with low phosphate at 0.40. And of note, she has strong family history of PE as well as hypercalcemia in her father and paternal grandmother's side. She was then referred to our endocrine clinic, and unfortunately, she didn't have any of her documentations or letters from the States. But according to the patient, she was diagnosed with primary hyperparathyroidism 11 years ago. And according to her, she was unsure that she was carrying a gene responsible for a condition, and that she underwent surgery and was told that she had ectopic parathyroid tissue. She had symptoms of severe hypercalcemia as well as oligomenorrhea, and denied any previous histories of kidney stones or fractures or galactorrhea. So we moved on to looking at her blood tests from her admission in A&E and our blood tests in endocrine clinic. And you can see that her calcium level has been persistently high, as well as her phosphate are low. She did have a normal PTH, and her vitamin D level at the time was normal as well. Moving on to our first Mentimeter question. What would be your differential diagnosis in this lady who had hypercalcemia post-para?
There you go.
Yeah. And if you guys can log on to Mentimeter. reach 25, we will show the results. Yeah, there we go. So MES photip is MEN1. That's ectopic parathyroid. And also we see FHH well. So yes, this is what we were thinking of as well. So we've done further work up towards these diagnoses. So we did a pituitary profile. We saw that her prolactin was high at 1,700. We did thyroid function tests, and the rest of her pituitary profile were normal. We move on to doing her imaging, and ultrasound kidney was unremarkable for any stones. DEXA scan was reassuring to be normal. Had a pituitary MRI report which shows there was no pituitary masses seen. She had also a parathyroid SPECT CT that shows there was no evidence that it was normal. We also sent off her urine, and her urine came back, and you can see we sent off twice. It shows that her urinary calcium was low on 2 occasions. It was less than 0.5. And her calcium creatinine clearance ratio was 0.00496. And she was polyuric at about 5 liters at each time as well, which shows that she was very symptomatic and she was quite thirsty as well. And I hope this gives a little bit of ideas as to where we might be leaning towards. Next, we've got our genetic results back, and it was consistent with a genetic diagnosis of a CSR-related hypocalciuric hypercal, which is consistent with FHH diagnosis. You can also tell from the test methodology, they also test for the MEN gene as well. And from the panel, it was negative for MEN. But from the genetic testing, we just. Meanwhile, over a year, we saw her again follow up in our clinic. We noticed that she had ups and downs of vitamin D levels, and she was replaced on that. But she did have persistent symptoms of hypercalcemia. And that's why we've got a clinical paradox as to why she's so symptomatic, like the diagnosis of FHH, and how we can manage this patient, whether we should start cinacalcet in her. Just a bit more information. This is her trends of graph. I think what is hiding above is the calcium on top. So you can see the trend from her presentation back last year up till now, that she's got hypercalcemia persistently, that she's got low phosphate levels, and that her parathyroid hormone has always been within the normal range. And of note, her vitamin D level here, you can see it dropped till below normal between March and May. Incidentally, looking back up to her calcium level, it was roughly the same time that her calcium level was close to normal range, but not as just yet. We wonder if this is also a picture suggestive and reflective of that effect. I thought is a good graph to see happen to us. So we're talking about hypercalcemia. What would you do for this patient in terms of, will you continue monitoring her symptoms, or would you treat it with cinacalcet, or would you think of surgery for this lady? Okay. So that is what we went with, cinacalcet. We started cinacalcet for this lady, 30 mg once a day. Unfortunately, she developed some disease spells after a week of initiation, and the patient herself decided to stop taking it for 4 days and presented into A&E with levels of hypercalcemia of 3.13, and was discussion with endocrinology, treated with IV fluids to rehydrate, etc., and decided to restart on cinacalcet at that end as well. On the other hand, in terms of the prolactinemia, we noticed we did a cannulated test and noticed that she has persistent hyperprolactinemia. And we thought about looking back on her MRI pituitary scans and look at what we can find there. I'm not sure if try to hide the arrows, you can appreciate there may be something within the pituitary area. And we re-looked at it in our radiology MDT, which confirmed there is a suspicion of a microadenoma and that it was a very difficult diagnostic comment from our radiologist as well, because of the contrast stages, but they are commented that it's suspicious. We'll go back to follow our patient and decide on what treatment more appropriate. So we thought it's quite an interesting case because we've got quite dual diagnosis and also differential diagnosis for her lady. And we thought to open up the discussion as to what you guys think of the case in a lady who's got high calcium and high prolactin levels. And some ideas of this discussion might be, why is she so sensitive for a diagnosis of FHH? Any roles of ectopic parathyroid tissue post-surgery, as well as what are the tips or any pitfalls in terms of pituitary imaging in microadenoma to open up for any questions. Very much.
Yeah, thank you very much. Very interesting case.
Was an interesting and challenging problem. Thank you. Could you go back to the pituitary imaging?
Imaging, yes.
Just there, no, well, that one will do. On the left-hand side there, it doesn't look like a microadenoma. They're normally clean and round and focal and have differential enhancement. But I do have this feeling that microadenomas don't become macroadenomas very often. And so macroadenomas were probably born to be big, even though they were small once. So I wondered if that is diffuse lactotroph hyperplasia on the right that might become a macroprolactinoma in a decade's time. It doesn't look like a micro to me. It's just irregular and slightly worrying, very asymmetrical. Was that discussed? Is there any thoughts about that? I think it's easy to take the word microadenoma and incorporate it permanently in the notes forevermore when it might not just be right.
I think it was a difficult diagnosis that was discussed in MDT as well. And the formal comments from our radiologist consultant was that it might be a different phase in contrast, and that this was an imaging that was back from 2024 when she was first presented in terms of workup. So maybe opinions of whether re-imaging is important or any other modalities might be recommended.
Yes, so just to comment, so that's the first MRI that was reported as normal. We had a little bit of discussion in our MDT radiology. So even the radiologist, it was more of the suspicion, as she put, is more of a suspicion of macroadenoma. We still didn't put like a definition, like a decision about starting cabergoline. So no, keep monitoring and see how it goes. The thing is just the patient has this irregular period, nothing more. So probably we'll follow up with images and see. It's like we have a lot of non-answered questions in this case, actually.
Irregular. Okay. So has she been given some cabergoline? Might be worth trying.
Hi. I'd like to know more about her Lyme disease. Patients I've met with Lyme disease are universally very unhappy, with quite a lot of overlap with the symptoms that you're pushing towards hypercalcemia.
Yeah, didn't put onto the slides, but she was under detailed follow-up in the States with multiple kind of serological follow-up, and they have cleared her from any follow-up. They're happy with that.
Did she have it?
Did.
So that's one of the problems we have with this case is just we started seeing her last year and we are still waiting for her to bring the documentation. So everything from her past medical history is her saying, I have chronic Lyme disease. She had surgery to have a scar, but yeah, many things are, yeah.
Okay, thank you. So Any other thoughts on the case?
Go on, Jeremy. I know you want to say something.
Yeah.
I don't want to hold everyone up because I know it's getting late. But I suppose the big question here is, the phosphate's interesting. The first question is how she presented in the States and was she symptomatic at that time? So if I just gave you an instance, we had a case like this a couple of weeks back, around COVID time, calcium 2.62. Now the calcium is 2.9 and she's symptomatic. So your big question, I mean, is it the FHH is naturally presenting as primary hyperpara type picture? Or is it that actually she's developed primary hyperpara on top of an FHH picture? And the phosphate is a bit suspicious for having done that. And I hate to say it, but that phosphate also slightly makes you worry about other things. She didn't have rickets when she was younger or anything similar. Is Alex here? Alex has disappeared. Okay. So yes, I mean, you've just got to think of a tertiary process when you're looking at a phosphate running this low. So yeah, we've had cases who had X-linked hypophosphatemic rickets actually from a younger onset leading to tertiary, or we've had people with IIH, so a NAPI transporter defect leading to phosphate wasting lifelong and tertiary hyperpara. It's just a little bit odd, isn't it? That phosphate, that's pretty significant, a phosphate going under 0.5. Yeah.
Calcium's high, isn't it?
There's a lot to think about there, actually.
What's our advice to the?
But it's all on history. Get all that. I think people would agree. I think get that original history, see what the difference is. What was the symptomaticity originally in America due to? Was that Lyme or was that calcium related? And then consider whether actually she's a primary hyperpara presentation of FHH or developed it and needs surgery as a result, because it does sound as though she pretty well might need surgery. Don't know what surgeons feel.
Yeah.
Comment? Sorry?
Yeah, my answer on behalf of the team. You know, these are really complex cases, and I agree there's some diagnostic uncertainty, exactly as you've said, isn't there? This is pretty unusual, and so you need to get a bunch of people together who are used to looking at unusual things. And it may be that there is an alternative explanation. Jeremy's been very persuasive with Exeter Genetics in the past and had them run other panels in addition for hyperphosphatemic causes, etc. And it has also been very persuasive in the past in making us do things like total parathyroidectomies for, you know, people with pseudo hyperpara, and he's done the same thing to me in a young patient with X-linked hypophosphatemic rickets who previously we thought had primary hyperpara and didn't resolve after a subtotal. So it depends who's asking.
Okay, we've got a few questions here online. Vitamin D was checked with MES spec. So which lab do you go to?
It's your lab, Patricia.
Our lab.
Yeah.
Should have. Yeah, we do reflex some of these. Although actually we reflex the high levels. So if you want a vitamin D, we could always check. Uterine fibroids as a source for prolactin. That is unusual. I think probably not, right? Common things, common. She's got irregular periods. She's got hyperlactin. Yeah, I would treat that. And then has CDC73 mutation been checked? Yes. Other panel. Yeah. Okay.
Okay. Thank you all very much. Now, before I hand over to Fausto, just to say, if you want to give us some feedback, please click on this thing. You'll get a certificate automatically within about 10 minutes. But do write something down for all the speakers, and most importantly, write a few phrases about how we can do better next year.
Yeah. And if you say nice things, you get a certificate. If you don't, well, on consider. Listen, I'd like to thank everybody. Obviously, all the speakers, the 120, you know who you are, who are online rather than in person. I hope the next year you will come in person. I think it's been a great day. And obviously, I want to thank in particular our friends from Alabama who have contributed very memorably to this day. So thank you all. Safe journey home and have a good weekend. Thank you. Until next year.